we would work with the state contract manager to also identify who would be reviewing those. We obviously have a large party here and want to make sure to build in time frames for those reviews. We also want to assure you that we have internal continuous quality reviews. All of our work goes through multiple reviews. Every deliverable that's submitted would be reviewed by myself as the project director and our project manager. And in terms of the data analyses, we have reasonable checks and would review for accuracy. The task force has requested monthly attendance to provide status reports, and we have particular agenda items we assume we would want to address, but would also be flexible to address others as you all identify. We would share any preliminary findings once we have those and issues around those findings. In that, we would respond to any of your questions. We would also do brief updates of our project plan status, identifying, as we've indicated, the challenges that we've had and the mitigation strategies for those, and then provide a brief overview of what our upcoming tasks are to be. This next slide shows our proposed project implementation plan. It's actually broken out over 2 slides. But we approached this proposal assuming that most of our work would be conducted and completed by October 1st when the report is due. We recognize that there is potential for ad hoc assistance and are flexible to that. But as you can see, across all of our tasks, the majority are completed by October. In terms of our developing our recommendations, we'll go through on the next 2 slides in more detail, but our overall approach would be to conduct the data analysis. We do know that it's important to get internal stakeholder input, and so we would want to interview individuals across certain state agencies that are involved in both of the programs to gain their perspective. As we mentioned, we have many subject matter experts from whom we can draw their experience, and where needed, we would conduct supplemental national research. Throughout this process, we would be collaborating with you all to make sure that we're on target with what we're looking for, what your needs are. We proposed an evaluation and data analysis plan, but this document will evolve over time as we identify what data is available, as well as what source reports have already been completed. We will go into a little bit of detail later about the categories of data and analyses that we've recommended. And then, again, once we've had our initial meetings, we'll revise that as we identify what data is available, as well as any input from the state about the analysis. In that, we'll also leverage our internal expertise and research capabilities. We have a research group internally that we tap to look into certain databases that we can access data and so forth. Just to summarize, we've kind of hit on these already, but our data collection and analysis process would be, it would start with the state, working with you all to identify what's available, whether we'll be able to receive Medicaid claims data and so forth. We would also do a scan of studies nationwide that might show best practices or have trends available for comparative purposes. We would view the methodology employed in compiling the data in preliminary review. We want to make sure that we're receiving accurate data. So we look at the data received and document our methodology for reviewing that. And then we also will catalog all of the data that we've received as well as what we've requested so that we make sure that we've identified where the gaps are and how that might impact our ability to complete the analysis. This file would also be used with the state contract manager for status updates and where we might be having challenges with obtaining some of the data that we might need. Once we've gathered all the data, we would collect the primary data analysis as well as secondary analysis to form our observations about the current state of your programs, as well as to begin forming our recommendations for alternatives to those programs.
RFP made it very clear that there is a lot of data available and that we do need to validate the sources of that data before relying on it. We did, in preparing this proposal and in some of the other research we've done for other programs, we have come across a significant amount of data and research that's already available about your program. And we'd certainly like to understand where that came from and if that can be used rather than trying to duplicate what you've already done.
Again, we would anticipate that with this project, as with most evaluations, there is some supplemental research that goes into that. This slide displays our general approach to conducting research. We always tailor it based on the state as well as the study being conducted. But generally, we would develop the study questions, how successful other programs have been, what innovations we're looking at, are they cost effective, why are they cost effective, what has that state or entity done in particular to have a successful program. Once we've identified the innovations we want to target for the research, we would look for particular states to study or entities such as Medicaid managed care plans, commercial payers, and so forth. In looking at other states, we want to make sure that they have characteristics similar to Arkansas, so that the lessons learned might be applicable, and we would take those, but also understand that there are differences across different state agencies. We would then conduct the literature reviews. We'd like to gather as much information as we can through our subject matter experts as well as literature reviews before going to a state to do interviews. It's a very time-consuming process, and we want to be aware of that and not waste their time if that information is available publicly. So in order to target our questions for any interviews we do, we would prepare first by the literature reviews. We would then determine if there are states that we might want to survey. It may be that with these other states that have the alternatives to expansions, we want to explore a bit more about what their actual costs are that aren't necessarily published and how that might compare with the other states, and if the benefits might differ and what needs to go into that review. And lastly, as I mentioned before, we do recognize that considerations of internal as well as external stakeholders is very important when you're making any sort of reform. And so as part of the study, as you all requested in the RFP, we would look at what agencies are involved in each of your programs and look to interview individuals from those agencies so that we can understand what their perceptions of the programs are and where they see that changes might be necessary.
In the next pages we have the evaluation topics and analyses, and I'll just go through those very quickly. We'll be looking at the eligible populations, resources and funding. We'll be conducting a verification of Medicaid eligibility. We noted that there's issues with regards to previous reports that discuss the potential of individuals being deemed eligible when there haven't been the proper safeguards. We want to look at issues with regards to access to quality, the healthcare needs and relevant characteristics of the populations to be covered, take a potential examination of the economic impact of the expansion program or the private option program, and we have economists who have conducted market studies and analyses of the impacts of insurance programs on the market and on the environment in the state. Other issues include comparison of state plans, the impact and retention of physicians. There's been a lot of research done recently about what's exactly happening with the supply of providers and whether additional Medicaid coverage expansion or other options have served to promote access to care for individuals, including these of other kinds of physician extenders. We want to take a look at Dave talked about the private option on hospitals, and taking a further look at the impacts of premium assistance and then we'll be looking at Medicaid service trends and Medicaid modernization. So I'm going to go quickly then to the Medicaid modernization slides. So Don, we talked a little bit more about that.
So as part of the audit, or which won't be a formal audit according to generally accepted accounting standards, but we understand what you're looking for, a review and evaluation. But as part of that, we're going to look at services that are being utilized across the Medicaid population. How many services by enrollee is something we might talk to you about, but we really want also to focus on those areas of utilization where the largest number of expenditures are being extended, and also where what the costs are for prescriptions and which services are being utilized to the greatest extent. Going to the next slide. Prescription medications are a major cost for Medicaid programs, and so we're going to look at the utilization that's going on in Arkansas. We're also going to find out whether Arkansas could be doing more to control their prescription drug utilization, looking at what other states are doing.
Can I ask you a question? This slide that you just passed interests me a lot. Can you go back for the modernization recommendations? One more. Right there. So this is off of Arkansas data for 2014, is that right?
Yes, this is like fiscal year.
And this is for the traditional Medicaid program? This is some of the data, again, that we're going to be looking at, and it's somewhat challenging to get, but you're showing 3.9 billion of it is for hospital and medical. Does that include primary care physicians, and what all is grouped into that? Because I see you've only got it broken into 3 categories: drugs, long-term care, hospital, medical. So it's hospital, medical, basically everything except long-term care and drugs.
Your question is well founded, though. Typically, we find that physician expenses are about 7 or 8%. Hospital expenses are about 30%. And we can go through and I could cite a hospital factor in one of the areas I work in more than any other area. And when you add in imaging and post-acute care and other things into hospitals, the hospital industry, directly or indirectly, controls the spending of about half the Medicaid dollars.
But your previous studies show that the physicians part of that pie is 7 or 8% normally?
Yes.
And when you say that the rest of that is those other items under hospital, that's a lot, obviously, in hospital/medical. Are there physician costs included in that as well? Hospitals or on contract?
Yes.
Yes,
That's correct.
thanks.
Okay, we're still on slide 42. One of the issues that was raised in the RFP was about provider performance and overutilization services. We looked at some studies that have been done, and it appears that there have been instances where providers have not appropriately documented services, that they perhaps are billing for services that they didn't provide, they're upcoding improperly. And we also found that there was a review that CMS did that it looks like maybe the state has not been using its tools as effectively as possible, particularly the service system for overseeing provider utilization. So we would look at what the state's been doing and how it is monitoring provider utilization. We want to talk to people in the Medicaid OIG, the Medicaid Fraud Control Unit, looking, and as well as, of course, Medicaid program staff, and find out where there are issues and how other states have addressed these issues.
We just finished doing that very work for the state of Texas. And the state of Texas released their program integrity group up into what's called an OIG, for their Health and Human Services Commission. And of course, they're one of the largest Medicaid programs in the nation. And we addressed the audit function, the investigative function, and the program integrity function. And program integrity changes over time. As you have a primary care medical home model, very different than what other states might pursue under a traditional managed care environment, bundle payments to physicians, a myriad of other approaches. What's important is that we just in Texas, we're in the process of doing that work in Mississippi, we recently finished the state of North Carolina, and we're wrapping up the state of Alabama, all of which we're addressing those program integrity issues to make sure that the Medicaid program and/or the Medicaid fraud control unit within the Attorney General's office have the information that they need to spot abhorrent practices by providers or people that are being enrolled.
Well, while you're on that, this is one of these areas where it seems like sometimes the incentives get perverse and we incentivize people to do bad things, and then we get into an inspection mode and we require lots and lots of paperwork, and then if somebody misses a dotting an I or crossing a T, that becomes the focus. So is anybody doing anything that changes that model so we get away from just inspection and fraud? We need to do that. We copied Texas. I think Senator Sanders sponsored an OIG bill here in Arkansas a couple of years ago, so we're onto that too. We may need to improve it, but I'd love to see if there's a way for us to change the game rather than just I can inspect better than you can inspect.
Well, that's what we recommended recently, which is a different. I spoke to the National Association of Medicaid Program Integrity. I was an invited speaker a number of years in a row, also with the Human Service Finance Officers. And what we tried to discuss then, that was not resoundingly endorsed, but is now all of a sudden people are interested, is that program integrity function shouldn't exist for the sake of program integrity. What it should be doing is constantly testing the environment to make sure that the people who made the decisions made the most efficacious decisions, and they need to start reporting back real time so that people that are making Medicaid policy, rate reimbursement issues, setting rates, establishing provider networks. Right now, most of those entities nationally exist to go and catch people. And I would argue that that's a very ineffective model. What they should be doing is constantly communicating with the clinical staff, with the policy staff, with the finance staff, with the budget staff. And I would tell you that 80% of the states and 80% of the Medicaid program integrity programs nationally don't have an annual plan. They ought to, whoever calls up, whatever the hot issue is, they haven't communicated with leadership to have a plan, which of course changes, but there's still a plan. They also don't provide an annual report. If you don't provide a quarterly report, annual report, you've gone and caught people for nothing. And I can tell you that by the time you go through all of the appeals process and the settlement process, it's much more efficacious to not incentivize perverse behaviors than it is to go and catch people that are acting in a perverse manner.
Catch and release works for fishing, but maybe not here.
I'd like to say that it's also, I found in a survey I did of home and community-based providers in states around the country, that states were often not using enforcement mechanisms they had available to them, or they weren't sufficiently small. So I mean, you were dealing with a small infraction with a hammer, huge hammer, and corrective action plans, for example, in the state of Ohio turned out to be very effective in curbing abuse by personal care providers. So really getting in there and then following up on those corrective action programs and plans.
Senator Sanders, did you have a question?
You're recognized. I was going to ask a little bit about what we're doing, those things that you outlined. We did follow the Texas model in terms of how we require reports and a plan. But one of the things that we're working on, and our Inspector General is here too, is the utilization of advanced analytics to data mine and front end, so it's easier to prevent something from happening than it is to go back and to identify and do a retrospective all the time. Is that David, is that what you were?
Absolutely. And you look at Texas, for them not to have noticed that they provided more orthodontia care in a 9-month period than every other state in the country combined. Somebody wasn't quite watching the computer screen. So yeah, by being able to look upfront at provider prescribing patterns, their prescribing of imaging services, the whole thing. It's a lot easier to know upfront than it is to go try and catch people 2 or 3 years late. One of the other issues, though, that you bring up that I think is tangential is the federal government usually comes in and is auditing you 2 or 3 years behind. So when the federal government comes in next year, if CMS comes in and does a financial management review, or the OIG comes in, they're going to be looking at 2012, 2013. So I think it's important not only to get things right going forward, but as I mentioned earlier, to make sure that historically you can reconcile the monies that have been drawn down. Because once they come and find a problem historically, they're going to take it forward and back to see just how much problem they can identify. So you're absolutely accounting.
And we have to repay that money, and they extrapolate, so it could be a big cost to the state as well.
Senator Chesterfield, you're recognized for question.
Thank you, Mr. Chair. You have begun to talk about, to some extent, how the state can work to reduce costs. How many states are actually using the bully pulpit of the state to reduce pharmaceutical costs as well as to control other costs? I don't want us to get into a Robin Cook model where we just let people die and all of that, but I do want to know how the bully pulpit of the state is being used differently than in Arkansas in order to control not only the cost of the Medicaid program, but we are charged with the totality of the medical industry. What are you seeing as trends in that area?
I would defer to my colleagues, but quickly say that no one's doing it as well as they should. When we go to states like Georgia, or take Mississippi, when you combine the state employees health plan plus the Medicaid program, plus inmate population, plus workers' compensation, that's 50% of the covered lives in the state. They've got the biggest market, period. They can dominate. But the industry has everybody split up. The industry, the pharmaceutical industry, the medical device industry, the hospital, they understand that there are different buckets within the state, and they look at it collectively. Unfortunately, the state is often very siloed. The states that have tried to go and hire a czar, a healthcare czar, to look at the continuum of healthcare dollars that are being expended and find those benefits, are doing better. But as an example, I tried in the state of North Carolina for 10 years to convince them that they could take inmates, put them on Medicaid when they were getting inpatient services in the hospital, because you can't be an inmate and an inpatient at the same time. And it took 10 years to get the state to do that. Now they're saving $50 million a year by leveraging those two programs. But corrections and Medicaid just don't traditionally talk to each other.
And I guess that's why this task force has the opportunity to do really great stuff, in spite of the fact that I'm on the committee. But we have the opportunity to do some things that you're speaking, because it does not make sense to me that we, being the huge client that we are not getting greater bang for our buck. So thank you so very much, and thank you, Mr. Chair. I appreciate it.
Yeah, yes, ma'am. And if you want to continue.
Yes, thank you, Warren. Slide 43. Just quickly, we had done some research about your current case management tracking system in Arkansas, and it looks like that the state transferred over to the current system, which was processing eligibility and doing other tracking for not only Medicaid and social welfare programs, but the private option as well. And we want to look at how that's been rolled out and whether it needs to be tweaked, whether it should be kept, and also we want to look at how it's working with other systems in the state. And then the second bullet here, the opportunities to improve administrative efficiencies around state contracts. We understand that there is some overlap, maybe quite a bit, among state contracts, duplication, contracts where the state's paying for an outside vendor to do something that state employees are doing. And so, and this is where I think my legal background will come in handy is we're going to look at those contracts, evaluate them, compare them, and find out where administrative efficiencies can be achieved. And then we've talked about the pie chart. Going to slide 45. Medicaid eligibility. I mentioned I have some background in issues with eligibility determinations, and it sounds like, based on a study that the DLA did, that there may be a fairly high rate of errors. And so we want to look at a random sample of eligibility files. We want to find out what's going on. I'm very familiar with issues with spend down and long-term care eligibility processing being particularly difficult because you have to examine a person's assets, and they can be all over the map, and often the beneficiary or the applicant may be part of the problem, not bringing in all of the required documentation. So we will examine what's going on and find out, maybe there have been some improvements with the new simplified eligibility system that the federal government instituted last January, the MAGI system. The service trends, we want to look at trends in program expenditures and find out, have there been changes over the last few years? Where is Arkansas spending the most of its Medicaid dollars? And probably it's with the top 5 or 10% of the high utilizers. And what are the services that those folks are using? Are they using more? Are you seeing more issues around behavioral health? We know that around the country, behavioral health is really driving service utilization. And those are the people who are the frequent flyers in emergency rooms. And then provider performance, we talked about that, the provider compliance issues.
So I'm going to cover the next couple of slides, but they are an extension of the topics that Amy has already covered, and in light of time, I'll go at a very high level through them, and if you have any questions, please feel free to interrupt. For pharmacy utilization, I think the key issue is really looking at reducing the spend without denying the coverage. And so it's looking at preferred drug lists that other states are utilizing. You see a trend in the states in merging mental health and physical health under one umbrella. So the physical health medications, you've got 20% of your medications right now are for mental health. That's a very large part of your budget. So 20% of your budget is on mental health drugs. And I think just as a clinician, knowing that every part of an illness or every part of someone's illness process is part of its mental, and not really taking into account depression and how that impacts someone's ability to manage and care for themselves, and then not looking at the medications and how they factor into how they utilize pharmacy and how those medications are covered will be a big part of that examination. With regard to case management, you want to make sure that the new system that was implemented in 2014 is interoperable with your MMI apps. Does it really transfer the files and the information that you need to really manage the patients that are clinically complex and have those behavioral and physical health issues? For contract management, I think we have more than probably 42 contracts out there that probably cover duplicative services. And the thing that is kind of sticking in my mind, and my colleagues may hurt me after this, but I just have to ask about your SIM, which is a fair amount of money that covers 80% of your population that will be implemented, that may be even another layer of duplication on top of your existing contracts. And so just to think about that huge issue, that huge effort that's going on in your state, and what trickles down out of what results from your innovation grant.
Excuse me, ma'am, for the slow learner club like me, SIM, S-I-M, can you tell me what that is?
Sure, it's the State Innovation Model grant that was awarded by CMS, and Arkansas is actually in the implementation phase of that model. So there's a design phase, and you're pretty far ahead actually compared to other states in the country. And then when we look at comparing Arkansas and your administration to other states, it's looking across the country and looking at states like Florida, Kansas, Louisiana, what practices have they employed that have provided for administrative simplification? What recommendations and best practices could be applied to Arkansas where you are similar, and what can you learn from the mistakes that they've made so that you don't make similar mistakes? We're also going to look at block grants and other waivers, and what are your options with regard to those. Rhode Island, I think, is the only actual block grant that has been approved by CMS, so I don't know how similar you are actually to Rhode Island, but we'll see what we can glean and learn and apply from that application. And
We're way different.
I was thinking that as I flew across, and it took a really long time, and yes. And then we'll look at the legislative review and approval process. So what are your limitations right now, and what changes can be made to streamline the process so that there's some efficiency in the system. And then as we look at kind of making recommendations, we identify, what do we expect to encounter as we do all this work and work in tandem with you and get information from the Medicaid office and other programs. And a lot of times what we see is the fact that there's so much complexity that is which your head hurt and there's a shutting down syndrome. And what we plan to do is map it out and identify where there are some commonalities and build those commonalities to make it a little bit simpler and a little bit easier to digest and make iterative so that we all can understand how to move forward and make recommendations that are actionable. We want to look at the programs and figure out, which program makes sense to build from. I think the key thing in my learning at CMS is if you design a program and you don't have an objective in mind, then it's really hard to go back to the beginning and measure your success. And so really thinking about what do you really hope to get in the end and building your measures and your monitoring around what you hope to achieve will help bring forth some really good strategies. There will be a fair amount of interagency coordination. We're not sure how open all of the stakeholders will be to the conversation and the digging and the questions, but we anticipate in partnering with you that we will get through that with some introductions. Stakeholder support and engagement is always a tricky subject depending on who that stakeholder is and how interested they are in moving forward or how attached they are to what's going on currently. And so we would be mindful of the communication that would need to happen with all groups concerned, how to tweak the communication and what messages go to which parties. And then just the sheer pace of health reform. I think it's coming I think we stand in front of fire hose most days. And we're trying to read and fly and eat and read and move forward and design programs, implement programs, and oftentimes we're